Disclosures, no financial disclosures or conflicts of interest involved in this talk at all. So the goals of today's talk, basically understanding the significance of coronary heart disease in women. So why are we talking about women's heart health and not heart health in general? Knowing risk factors for the development of coronary heart disease. Having familiarity with primary prevention strategies for coronary heart disease. We'll talk a little bit about the signs and symptoms, and we'll talk about screening and testing we might do to establish a diagnosis of coronary heart disease. Just some definitions up front, some things that could cause confusions if we're using acronyms, things like that. So cardiovascular disease, that is all encompassing. That is basically anything in the cardiovascular system. That could include things like heart failure, peripheral vascular disease, stroke. Coronary heart disease, you may also hear us call it coronary artery disease, predominantly corresponds to disease in the arteries providing blood flow to the heart muscle. Myocardial infarction, heart attack is typically what we mean by that. Okay. So coronary heart disease doesn't necessarily mean a heart attack, but you could be on your way to developing a heart attack. Right. And just as a broader view of cardiovascular disease, particularly with women, there are some syndromes that are, or some diseases, processes that are more common in women, things like Takotsubo's cardiomyopathy, SCAD, which we actually will touch on a little bit. There are some conditions that are more common in men, but then there's conditions that are quite common in both. We're going to focus on ischemic heart disease today, because unfortunately we only had an hour for this talk, and to tell you anything of any substance, we had to kind of narrow it down a little bit. So heart disease is the number one killer of women. This is why this is a very important topic to be discussing. Basically, there is over 300,000 deaths per year of women, and 1 in 5 female deaths, or potentially in the group you're looking at, 1 in 3 female deaths is caused by coronary heart disease. 60 million women in America, or 44% of the female population, are living with some form of heart disease. I should also mention that heart disease is the number one killer of new moms. Maternal mortality, this is the number one killer. So why are we talking about women's heart health? And that really comes down to disparities in care that women have experienced historically and unfortunately probably to some extent today. So there's a series of biases. One would be institutional biases, and that would be healthcare providers not listening to women's symptoms, downplaying symptoms women have. Research biases. So historically, women have been excluded from a lot of studies in cardiovascular disease. We'll talk a little bit about that and things that have happened to improve that over time. And public bias, so societal pressures or beliefs, the idea that heart disease only affects men, that this is a disease of older men and women are less likely to have it. So disparities in care. Women with heart attacks are less likely to receive guideline-directed medical therapy. They're less likely to receive urgent intervention. So from the time you show up at the hospital with, say, symptoms of chest pain, there's a longer period of time between men and women in getting into the cath lab. Time from symptom onset to presentation is historically longer in women. Women are more likely to downplay their symptoms, stay at home, and say, maybe it's just indigestion, maybe it's just anxiety, where men were more likely to call for help early on. Unfortunately, historically, these problems, these disparities in care have led to worse mortality for women. And over the last 40 years, women had higher mortality rates after a heart attack than men. Women typically had longer lengths of hospital stay, higher bleeding rates, particularly after procedures, so after things like coronary interventions. Higher 30-day readmission rates, so after you've healed up from your heart attack and discharged home, women were more likely to end up back in hospital earlier than men, and higher rates of heart failure following heart attack. Now, some of this is due, again, to those institutional biases. Some of it is related to physiology. Women are older typically when they present with heart attack. The average age of presentation for a heart attack in men is 61. Can anyone guess the average age for women?
75.
So I heard 75 is close. 70. 70 is the average age. So women tend to be a little older. The type of heart attacks women have is sometimes different than men. So women are more likely to have what we call syndrome X historically, or microvascular disease, small vessel disease that's less amenable to stents or interventions like that. So all of these factors have led to higher rates of heart failure and unfortunately mortality. Physicians aren't great at listening to women, unfortunately. And there's, even more recent studies showing that patients treated by female physicians had better outcomes than those treated by male physicians. This was regardless of whether the patients were women or men, as it turns out. The hypothesis is that women are better at listening to patients. And obviously, 4 out of 5 women have felt at times that their healthcare professionals were not listening to them, not taking their symptoms seriously. I'm sure, yes, I'm seeing some nods in the audience. I'm sure everyone has experienced that, unfortunately, at some point. So this is actually, where a lot of these interventions, and the reason we're having this talk now in February, Women's Heart Health Month, have come from. We'll talk a little bit about that in a minute. So I talked about disparities in research and biases in research. So historically, women were excluded from a lot of the landmark cardiovascular trials. This was recognized as a problem by the NIH, the National Institute of Health, back in the 80s. So they initially put in a policy that said women should be included in research. Unfortunately, that wording was not strong enough. And it seemed what was happening was a lot of researchers were just not listing the gender at all of the research subjects. So in 1990, the NIH required women to be involved in cardiovascular research, as subjects, I should say, not as scientists. But so women were included in the research to see the effects on women. And as recently as 2016, the NIH required sex as a biological variable in all vertebrate science. And so that means if you were doing experiments on mice, experiments on cell cultures, you had to include females to see the effects that sex hormones, differences in gender would have on that. Historically, scientists didn't like to involve that because it adds variables. It could make it messier, but it decreased our understanding of the effects on women's physiology. So looking at those historical, disparities in outcomes between men and women, certain groups, including the National Heart, Lung, and Blood Institute and the American Heart Association, looked at this and recognized this and said, we need to improve awareness of women's health, not just for clinicians, but also for the population themselves. And so they launched this Go Red for Women campaign. So every February there's a campaign to improve awareness in women's health. They've been doing this now for about 20 years, trying to get people to recognize risk factors, signs and symptoms, and the need for screening. It seems to have worked. So this is cardiovascular deaths in the thousands. And so you can see here, obviously women overtook men, but there's been substantial improvement in that disparity. Now, these numbers are kind of old. Unfortunately, we've backpedaled a little bit. So cardiovascular deaths are on the rise again, unfortunately. Some of this may be demographics, but some of it certainly is, public awareness. I'm going to hand over to Brooke now. She's going to talk a little bit about risk factors for cardiovascular disease.
Hello, everyone. All right, so we're going to start by talking about risk factors for cardiovascular disease and then sort of move into prevention. Over here we have our traditional risk factors, so hypertension, high blood pressure, high cholesterol, diabetes, smoking, strong family history, and these really apply to typically both genders. Some that are female specific would be a history of preterm delivery. There's also several conditions that occur during pregnancy, which later in life can increase risk of cardiovascular disease. These would be things like gestational diabetes, which increases the risk of cardiovascular disease by 4. Preeclampsia, which I'm sure many of you have heard of, it doubles the risk of cardiovascular disease. These are important things for us to ask in visits when we're speaking with women. How many children do you have, and did you have any of these conditions? This also would apply for radiation for breast cancer, particularly to the left breast. 10, 20 years down the road, this can develop into plaque in the arteries, and occasionally calcifications on the heart valves. And then this would go for autoimmune diseases as well, rheumatoid arthritis or lupus. This is created by the American Heart Association. This is the Life's Essential 8. This is just a helpful resource for preventative strategies and something that you can always look back on. Some important strategies: sleeping well, not smoking, not vaping, weight loss, blood sugar, preventing or treating diabetes, treating blood pressures, heart-healthy diet, and routine exercise. So we're going to start by talking a little bit about diet. The diet that we typically recommend is the Mediterranean diet. This is a diet that's focused on high fiber, so whole grains, fresh fruits, fresh vegetables, beans, nuts, and healthy fats such as avocado and olive oil. This was a study called the Cardiovascular study, and it really showed a huge improvement, or I would say risk reduction in cardiovascular disease with the Mediterranean diet. This was out of Spain, and they divided into several groups. The first group was eating a low-fat diet, while the others focused on olive oil and nuts, walnuts specifically. And what they found was a 25 to 30% reduction in cardiovascular disease. Just some things to avoid. High sodium, which can be a little tricky when we recommend a Mediterranean diet. Things that you buy in the grocery store, nuts and beans, tend to have a lot of salt in them. And so what we do recommend is looking at the labels, understanding nutrition labels, and knowing where to look when we're looking at sugars or saturated fats, and avoiding processed meats, bacon, salami, ham, all processed and high in sodium. We do recommend limiting alcohol, preference is none, and not smoking. And exercise, as everyone knows, has great benefits. It does reduce your risk of cardiovascular disease and stroke. And it also reduces your blood pressure, blood sugar, cholesterol, all the other things that we tell you to prevent or work on to reduce your risk. It also helps with your mental health, helps with sleeping, helps you relax, improves your energy, and can help with weight control. We frequently get asked, how often should I exercise? What should my goals be? The American Heart Association recommends 150 minutes a week, which is about 30 minutes a day, 5 days a week. And when we say moderate intensity exercise, what we mean is we want you to get your heart up a bit. We want you to feel that you're moving. I always say, if you're walking with a neighbor, you may be able to have a conversation, but it might be difficult to sing a song nicely. You can incorporate aerobic exercise if tolerated, and these would be things like running or cycling. That always gets your heart rate up a little bit more and gives you a little bit more reduction in cardiovascular disease. All right, so we're going to talk about cholesterol. We're going to actually talk a lot about cholesterol today, so I'm going to start. There's a lot with cholesterol. There's your HDL, there's your LDL, there's your triglycerides, but we are just going to focus on two aspects today. One is your HDL. This is your good cholesterol. This does tend to be higher in women, and that's actually due to estrogen. This is the number we want to be high. We want this one up. And the way to do that is diet, exercise, weight loss, smoking cessation. The LDL is the bad cholesterol, and this is the one that we want low. And the reason we focus on this one so much is that there is a very close relationship to high LDL and cardiovascular disease, as well as decreasing the LDL and decreased risk of cardiovascular disease. Similar as to increasing the HDL, diet, exercise, healthy lifestyle. So their question always remains, when do we suggest lipid-lowering therapies or medications such as statins to reduce your cholesterol? So you get your LDL. If your level is higher than 190, that's unusual, and it is likely because this is a genetic cause. This is likely a familial hyperlipidemia, and our recommendation is to do some testing on that and to get you on medication as soon as possible. A majority of people fall in the category of less than 190. And how do we determine who needs to be on a medication with lifestyle modifications or just pursue lifestyle modifications? We use this score, which may look familiar to some people. This is the ASCVD risk score. Here we use your age, your gender, sex, your race, your blood pressure. We put in all those cholesterol numbers that we talked about, if you have diabetes, if you smoked, or if you ever smoked, and are you on blood pressure medications. And this spits out a number to us. And depending on what that number is, anywhere between 7.5 and above, we are recommending a statin, particularly for people that are on that have diabetes. There is an area where people are borderline, and this is relatively common. Most of these are the risk factors I mentioned before. And so I'll just give you an example. So we're in the clinic, and we have a 55-year-old woman who comes in. And we get her cholesterol levels, and we do her score, and we get a 5.6%. And that means that her risk of heart disease or stroke is 5.6 over the next 10 years. Believe it or not, that sounds high, but that is a borderline range for recommendations for medications. What would make me feel that maybe we need to consider putting her on a medication? Well, maybe she tells me she had preeclampsia. Maybe she tells me that her mother and brother both died of a heart attack in their 40s. And maybe she has some kidney disease, right? And we put those things together and we have a conversation about risk and benefit of medications. And from there we determine what's the next step. And I'm just going to briefly talk about biomarkers, blood tests related to cholesterol. There are some blood tests, more coming out every day. Lipoprotein A, ApoB, or high sensitivity CRP. These are all blood tests that you can really get from your primary care provider or any doctor, and would tell you that you are at increased risk of heart disease. And how do we incorporate these when it comes to cholesterol? That is really the same as any of these other risk factors. So we say that your risk is higher. Do we pursue them? Do we not? Some of that really depends on that shared decision-making conversation. The last part of that is coronary calcium scores, which is something that we're going to talk about later, so I'm not going to get into that too much. Okay.
Thank you. Statins have become a controversial topic. They shouldn't be. Statins have been well studied over the course of the last 30 to 40 years. So a lot of this data goes back to 1995. I was in grade school when this data was coming out. And there is a clear linear relationship between LDL cholesterol reduction and cardiovascular risk reduction. And so the lower we get that LDL cholesterol, we see decreased stroke, we see decreased heart attack. And that the science of that is very, very clear. Statins are still the best tool in the toolbox for doing that. They are cheap, they are effective, they're generally well tolerated, and they're generally very safe. We will talk a little bit about some of the newer medications, but again, decades of research. Statins are very safe. Only about half of the people who should be on them in the United States are on them. Major side effects are extremely rare. So in large studies, it's somewhere close to 1 in 10,000 patients having major side effects, would include things like severe muscle damage or elevation of your liver enzymes. the number one complaint with statins is muscle aches and pains. Now, in large randomized blinded trials, where half the patients were given statins and the other half were given a sugar pill, they've reported the same rates of muscle pain. Despite this, it's still been a real struggle. I think part of what has happened was there was a big campaign, probably about a decade ago, to really push people onto statins, and I think it probably overshot a little bit. I think there was some public backlash. And so, if you go online and Google statin side effects, you're going to get bombarded with, websites telling you how terrible they are. The more recent data, again, because there's been such resistance with this, with muscle pain, they looked at something called the nocebo effect. And so in a series of studies, what they did was they told people they were getting a statin. They asked people to score their muscle aches or pains on it. And then they told them, surprise, you were on a placebo the entire time. So they kind of tricked them. And so it seems like it's a very powerful effect. If you believe you are going to have a side effect from a medication, you have a strong chance of having that side effect. And so this is preventing a lot of people who would otherwise, really benefit from this medication from taking them. So what do I do in the clinic? I really try to work with the patient to understand this, to understand that the side effects are very rare. And if you're having a side effect on one particular type of statin, you may tolerate another statin. If there does seem to be a relationship between the intensity of the dose and the side effects. So if we can lower the dose, we can change the dosing schedule. That sometimes helps. Other things we can do, we can look at if there's vitamin D deficiency. Sometimes that increases the risk of myalgia or muscle pain. If you have untreated hypothyroidism, that might cause it. But I'm really pushing patients to get on these medications because they are really good. In fact, I would argue that they're, aside from treating hypertension, the number one thing we can do to lower the risk of heart attack is stroke. Like any intervention, the benefit is proportional to risk. And what I mean by that is if I'm seeing a healthy 25-year-old with no cardiovascular risk factors, I'm not going to recommend a statin. So anything we do in medicine that has any risk at all, we have to think, what is the benefit, what is the risk, and what is the population we're trying this in? And so, I'm trying to think of an analogy for this. And basically, who would benefit more from wearing a life jacket in this scenario? Is it the guy in the kayak, or is it the guy on the major luxury yacht, right? What is the odds of them going in the water? And so any intervention we do has to be proportional to risk. I think I'm back to you. Yeah. And we can talk about statins more after. Oh, I guess I should just mention a recent change in therapy is the use of what are called PCSK9 inhibitors. So these are injectable medications that can lower the production of cholesterol directly. These are used in patients who either cannot really tolerate statins because of true side effects, or despite optimal dose of statins, we cannot get that cholesterol down. So there are other options available. We can talk a little bit afterwards if there's questions about that. Thank you.
Yeah. PCSK9 inhibitors they do an incredible job of losing LDL. Wild. All right, so we're going to move on to high blood pressure, hypertension. So the main takeaway here is that we need to treat blood pressure. This is called the silent killer for a reason, and that's because most of the time, people don't have symptoms. Unfortunately, that's why a lot of people, specifically that don't have access to healthcare, do not get diagnosed. Sometimes we'll see people who say, I don't want to treat my high blood pressure, I feel fine. But unfortunately, as time goes on, that is doing damage to your vessels and to your heart. Untreated, it does damage to your kidneys, your vision, can cause heart attacks, heart failure, and cause stroke and dementia. It is the #1 reversible cause of stroke in women. And in all of the deaths from high blood pressure, 52% of them are women. So what is the goal blood pressure? Hypertension is defined currently as under 130/80. However, there have been a lot of recent studies which have wondered if this is maybe not a little high, maybe we should be lowering this. This would be something called the SPRINT study, which studied 2 large groups. One was a goal blood pressure of under 140 systolic, the top number, and the second group was under 120. And what they found was a significant reduction in cardiovascular disease and events, as well as all-cause mortality in the group that had a more aggressive blood pressure goal. Unfortunately, as we get older, it is harder to tolerate medications. Adverse reactions are more common, and developing things such as orthostatic hypotension. So getting very dizzy, standing up, also very common. So often we're not able to reach that goal, and that's okay. But it is helpful to know that being more aggressive might be beneficial, particularly in a younger population. And then treating blood sugars. So seeing our primary care provider routinely, having our blood sugar checked with our routine labs that we have every year, and making sure that we're treating our blood sugar when necessary. There are a couple of new drugs that are out on the market. One is called an SGLT2, also known as Jardiance. There's also GLP-1s, also known as Ozempic, and there's a couple other ones there too. Both of those have shown cardiovascular benefits, interestingly, even in patients without diabetes. And so, depending on the indication, these are medications that we will use in cardiology.
Oh, okay, great, thank you.
Yeah.
Yeah. Inevitably, I get a question from a patient or someone sends me an article from the New York Times about aspirin. And so, and probably about 5 years ago, a lot of my patients who were taking aspirin for secondary prevention, so these are patients who had already had a heart attack, they've had stents put in, they might have had heart surgery, they were stopping their aspirin. And I said, do not stop your aspirin, you need the aspirin, what's going on here? They said, well, I read the New York Times article, it said we don't need aspirin for primary prevention anymore. And I guess I think one thing up front is primary prevention, you do not have a heart attack, you do not have established coronary disease yet, we're using it to stop the development of a problem. Secondary prevention, so you've had an event, a heart attack, you have established heart disease, we definitely want you to stay on your aspirin in that situation. So if anyone tries to tell you to stop your aspirin, you've had a heart attack or stroke, talk to us first. Now, with regards to primary prevention, why is there so much question about this? So there were 2 studies done. One was the Women's Health Study, and one was the Physicians' Health Study, and not surprisingly, one focused on women, and the other one was predominantly male. In the Women's Health Study, they followed women for about 10 years, taking a low dose of aspirin every other day. And they found the women who did this had a decreased rate of stroke. Interestingly, they did not see an effect on heart attack in women. The opposite was true actually in the Physicians' Health Study on men, where they saw a reduced rate of heart attacks, but not a reduced rate of stroke. So based on this, we said, hey, maybe these people should be on aspirin. So that worked its way into the guidelines. Well, so more recently, that's come into question. And so when they've looked at this again in more recent studies, they're not seeing any benefit to aspirin and seeing actually increased risk of bleeding. And unfortunately, some of that bleeding would be in the brain. So what's going on here? What happened over that time? Well, what happened was the population got healthier. And so if you recall, the earlier slide, the benefit of any intervention depends on the risk in the population. If you have people who are smoking more, drinking more, not controlling their blood pressure, not controlling their cholesterol, if you have a sicker population, then the benefit of aspirin outweighs the risk. As that population got healthier over time, they quit smoking, they started exercising, the risks of aspirin increased versus the benefit. So that's what we've seen here. So based on that, we've had to sort of shake up our recommendations on aspirin for primary prevention, and the New York Times has been covering this extensively. So who should get aspirin? I think it depends on, again, your risk overall. So not just your ASCVD 10-year risk, but also other things we'll talk about, your calcium score, your family history. It also depends on your risk of bleeding. Do you have a history of gastric ulcers? Have you had any bleeding in the head before? So it's not a straightforward question. The U.S. Preventative Services Task Force says you may give it to people who are at increased risk, but only before the age of 70. After the age of 70, they think the risks of bleeding outweigh the benefit, which is interesting. The American College of Cardiology and the American Heart Association have a more liberal approach to that, but again, it's all based on high-risk individuals. So the higher your risk, the higher the benefit versus the risk of bleeding on aspirin. I'm going to talk a little bit about hormone replacement therapy because this is a question that's really key to women. And so the Women's Health Initiative, again, I think run through the NIH, looked at this question. And so the idea was, if you recall earlier, we talked about the difference in the age of first onset from male heart attack to female. And so the thought here was that something happens at menopause and women are catching up with men as they age. And indeed, that does seem to be true. So the idea was that what if we use hormone replacement therapy? What if we used estrogen to delay that? Would there be advantages there? And unfortunately, when they looked at large populations with this, there was not an advantage. In fact, there appeared to be increased harm. When they looked at that in more detail, it seemed most of that harm was in women who were greater than 10 years past menopause. So in older women, hormone replacement therapy actually caused more harm. There was a trend towards more heart attack and stroke. In younger women who were perimenopausal, there did seem to be some benefit, particularly in things like lowering cholesterol and blood pressure, things like that. It also depended greatly on the type of estrogen, whether or not it was estrogen and progesterone, whether it was synthetic estrogen or conjugated estrogen. My overall takeaway from all of this is there's not a clear benefit, and so it's not routinely recommended as a tool for cardiovascular health. Okay. So screening for cardiovascular disease, or coronary heart disease. Patients will come and say, should I have a stress test? Very simple question. Should I come in and have a stress test? If you do not have any symptoms, there is no clear role for stress testing in the general population. Okay. So beyond routine things like getting your blood pressure checked, getting your cholesterol checked, staying up to date with your physical exams, there is no role for excessive testing there. I talk about exercise a lot in the office when you're with me, and I talk about that for a couple of reasons. So the big one is obviously all of the health benefits that Brooke talked about earlier with exercise. But to be quite honest with you, I like exercise because it makes my job easier. And what I mean by that is exercise is an excellent early warning system. So inevitably, as we're coming into the spring now, I'll have patients come back to the office and say, doctor, I started walking again with my friend, and we're going up this hill, and I'm feeling really short of breath. And I have no idea if that is because you haven't done anything all winter, and now your physical fitness is down a little bit, or if it's a new symptom. So it's really helpful if you do the same walk, and it takes you 30 minutes, and there's one hill where you have to push yourself a little more, and you do that same walk, 5 days a week, and you come to me and say, that walk that used to take me 20 minutes is now taking me 30 minutes, and I'm stopping once on that hill because I'm so short of breath. That is an immediate signal to me something is changing, something's going on. So in a way, exercise is a screening tool you give yourself routinely. So you test your body and you see how it responds. Changes in that would signal you need to come and see us. Mm-hmm. I'm going to talk a little bit about coronary calcium score. So this is a relatively new technology. It's been around for a while. I think utilization of it is increasing over time. And what this is basically is we do a low-res CT scan of your chest, and as the X-rays pass through various tissues, they interact. So this is all air. The X-rays pass right through. There's soft tissues in your body. Some of them pass through, but the calcium in your bones, so this is the sternum and the spine, will block X-rays. They'll become radio opaque or white on the CT scans there. So what this is the left anterior coronary artery here. And so we can see the buildup of calcium in those arteries, which is a marker of disease in the arteries. There's a large group that looked at this, and they scanned, I think it was about 7,000 patients. And they took them from different ages, different genders, and different races. And what they did basically was create a bell curve or a normogram to figure out what does the average 50-year-old man of African descent have for coronary disease. And so they were able to kind of make a bell curve, and so we can figure out where any individual should fall on that curve. Are you higher than average, lower than average? And so this is kind of what we see in the scoring system. And I created these just to kind of give you an idea here. So I took a white female age 50 and a white female age 75, and I gave them both a relatively high coronary calcium score of 200, okay? And so for a 50-year-old white woman, a calcium score of 200 is actually quite high, okay? So you're in the 99th percentile, meaning if you took 100 women your age, you have more calcium in your heart than 99 of that 100, all right? Now, as calcium does build up in the arteries as we age, so it becomes more normal the older you get, and so then for a 75-year-old woman, you're in the 72nd percentile, so meaning that you do have more calcium than most women, but you're not off the chart. The other thing this also helps us with, it gives us an idea of like, how many people do we expect to have any calcium in that cohort? So, 16% of women in their women at age 50 will have some calcium, meaning the vast majority of 50-year-old women should have none. So this kind of helps us figure out what someone's risk is compared to their peers. And this can be really helpful in a couple of settings, okay? So now, again, as we expect that calcium builds up with age, I wouldn't really recommend this in, say, an 85-year-old coming in and saying, I'm worried about my calcium score. I expect at 85 years old, you're going to have some calcium in there. Now, we can always be surprised. You can have a lot more, a lot less, but it's not a very helpful tool in that setting. Likewise, a healthy 25-year-old. Actually, I was asked to read calcium scores on a series of firefighters not too long ago. And these are all generally young, healthy guys, and inevitably they were almost all entirely normal. So not a particularly helpful tool in that. I use this in people who are borderline. So if you came to me and said, my cholesterol is fine, but I have a history of high blood pressure and I have a family history of premature coronary disease. So a number of members of my family have had unexpected heart attacks in their 40s. This is a reasonable tool to use in that setting. So where we would not expect to find something, this can be a helpful tool. And what should we do with that information? It depends a little bit on how high the score is. It depends a little bit on the individual's risk. But this can often lead to stress testing. Okay.
Cool. All right, so we're going to talk a little bit about signs and symptoms of coronary disease. So we're going to start by talking about signs and symptoms of what we call is angina, meaning that you are beginning to build up some plaque in your arteries. You're beginning to have symptoms of this, but you have not quite yet had a heart attack. As Dr. Spencer mentioned, you're walking with your friend 2 miles a day. 3 months later you say, now I'm stopping halfway or a quarter of the way because I'm getting tightness in my chest, a heaviness in my chest, maybe symptoms of shortness of breath. Maybe you can't quite explain it. You just say, I just feel very tired and I feel that I cannot exert myself. Those are all symptoms that you should tell your provider about. These would all be a great indication for stress testing, okay, and for evaluating the arteries. Often these will come on at shorter distances. Maybe the symptoms last longer, and those can also be very concerning. And ultimately, going to the emergency room for symptoms that do not improve with rest would be recommended. We did include pain in your legs with walking. This would be consistent with plaque in the arteries of the legs. The pain in the legs is typically in the thighs and calves, and this is something we call claudication. But this is also something that someone may say that stops them from walking as far as they were. Typically improves with rest, but over time may become worse and really should have further workup and evaluation. So we're going to talk about stress testing. This is the standard treadmill stress test. We watch the EKG. We watch your blood pressure. We watch your heart rate. We watch your oxygen. We see how far you can walk, and do you have any symptoms. All of these things tell us a lot about you and your physical health, but also about your cardiovascular health. EKG changes are what we're looking for when we're looking for evidence that you might have plaque in your arteries or you're getting decreased blood flow. Keep in mind that the EKG changes in women can be abnormal about 20% of the time. And when that happens, that means that we need to do further tests, which we'll talk about. Functional capacity is an excellent predictor. So if you're able to go onto the treadmill and keep walking without symptoms until we basically stop you, that's a great sign that you're doing really well. As far as the other testing, here we have the nuclear testing, and just quickly the concept of that is that we take pictures of your heart or the perfusion, so the blood flow going through the arteries at rest, and then we either exercise you, or if you're not able to walk on a treadmill or exercise, we give you a medication that dilates your arteries. And then we take pictures again. And what we're looking for is did you have decreased blood flow or oxygen? Is there areas of your heart not getting blood flow when you're exercising or stress? And then here is just, this is an echo. A stress echo is a treadmill portion. Same concept I mentioned before. We incorporate an ultrasound or echo, which we'll take a look at how your walls are moving and how your heart is squeezing with physical activity, the pressures in your heart, and how your heart valves are moving. And so then we'll just move on to signs and symptoms of a heart attack. So for women and men, the number one symptom does remain chest pain. This can be in the center of the chest. Sometimes when I first started practicing, I would ask people if they had chest pain, and I would have so many people say no. And then by the end, they would say, well, I have a pressure, or I have a tightness, or I have a heaviness. So it's not always a sharp, excruciating pain. It can be really any sort of discomfort within your chest. This can radiate to the jaw, the back, really anything in this area. Some people don't have any discomfort. Some people get very short of breath. Some people feel very tired, like I mentioned before. And then occasionally, some people will have nausea and vomiting. What I would say is, with time, I think Dr. Spencer and I have realized that sometimes people will present with very unusual symptoms. Things that we would say, if you were to call the office and say, I just feel off, something feels really wrong, something's wrong with me. That's certainly hard to treat over the phone, but what's important is you know your body better than we do, and you know your body better than anyone else. And so when something is wrong and you think you could be having a heart attack, even if it's something as you just feel really abnormal and unwell, it's always important you go to the emergency room. That's where they do an EKG, and they do a blood test to see if the enzymes are elevated in your blood. That would indicate stress to your heart.
The one thing I will just mention on that, I think, as we talked early in the talk about disparities in healthcare and healthcare providers not listening to women, if you are worried that you are having some of these symptoms and having a heart attack, when you call 911, you say, I think I'm having a heart attack. Don't say I'm feeling tired or I'm feeling funny, because that will instantly get their attention. When you talk to the paramedics, you say, I think I'm having a heart attack, because that will instantly get their attention and start a series of protocols. When you get to the emergency room, you say, I think I'm having a heart attack, because again, that will get their focus right on you, rather than saying, I'm feeling tired, I'm feeling funny, and they sit you in the corner and send off for blood work and come back and see you 3 hours after you've completed your heart attack. So unfortunately, you do need to advocate for yourself a little bit and be clear. If that's your concern, say your concern.
Absolutely.
My add from this book, I also say don't go lay down and take a nap and feel better.
Right.
Yeah.
Exactly. Just go to the MD.
Just so I can do my fancy room. Yeah.
And as I said, I mean, we've both seen some very unusual symptoms that is not on this list, and I would not correlate with a heart attack or coronary disease, but yet it was. So know yourself, know what's normal for you, and know what's abnormal for you. All right, our last topic. So we're going to talk about something called SCAD. Has anyone heard of SCAD? The reason we wanted to discuss it was that It is primarily a disease of women. So 90% of women that have this condition 90% of people that present with this are women. It is exactly as it sounds here. It is spontaneous dissection of the arteries of the heart. It is the #1 cause of heart attack in women under the age of 60, and it is the #1 cause of heart attack in pregnant women. The reason that I do like to bring this up, because it isn't incredibly common, it's not something we see all the time, but since we are talking about the disparities in women and things that are often ignored or put very low on the differential diagnosis, this should be always at the top of the list when you have a young female coming to the emergency room with chest pain or concerns for a heart attack. It can often be the sign that something is wrong with the vessels themselves, and that there's a vascular condition underneath. Some of the conditions you may have heard of, things like Marfan's, Ehlers-Danlos, Loeys-Dietz. The most common is something called fibromuscular dysplasia. And so standard, if someone has this condition, we scan them head to toe to look for this. And I put this picture here, the picture up here to your right. Okay, I don't know how to use it, but it's this thing here. So the classic look on either, mostly CT, is what looks like a string of beads along the vasculature, and then aneurysm. And then how do we treat this? So this is different than when someone has a heart attack and we go put a stent in or we do bypass surgery. It is conservatively managed, and typically the vessels resolve or improve on their own spontaneously. Sometimes stents are used, but it can actually worsen and extend the dissection, which could be very worrisome. And bypass surgery is really only used in very high-risk cases. This can reoccur, and so certainly sometimes people do have those underlying conditions, and so we're worried about that. There are people that don't have the underlying conditions, but there is still a risk of reoccurrence, which I read multiple journals, it ranges about 1 to 4%, but it does vary. Beta blockers, medication like metoprolol, is really the only thing that's found that has reduced the risk of reoccurrence. But ultimately, there's not a lot of data and there's not a lot of research on this. Right. So thank you for having us. We're happy to take questions. Do you want to add anything?
No, I think just to summarize, if I could, what did we talk about tonight? We talked about the disparities that have existed and still unfortunately exist in the recognition and treatment of heart disease in men and women. We talked about some primary prevention strategies, so things like ensuring adequate control of blood pressure, cholesterol, exercise. We talked about screening tools we can use to establish if there's the presence or absence of coronary disease, the importance of regular exercise and knowing how healthy you're doing. We talked about a little bit about stress testing, signs and symptoms of heart attack, and the importance of not ignoring those signs and symptoms, and advocating for yourself when dealing with emergency responders or physicians. So thank you very much for having us. We'll be happy to take any questions you have.
So yeah, I have a question about the stress test. So I guess my 2 questions to it are, 1, why wait if you know a certain family history or signs or symptoms or labs or whatever it may be? And then 2, do you repeat a stress test, let's say 5 years, 10 years post, heart attack or whatever it may be?
Yeah, great question. So in case anyone didn't hear that, the question was, if I may summarize, why wait on a stress test if you think you have a positive, or if you have a strong family history of heart disease, why would you wait to do a stress test? And the second part of that question is, if you do have heart disease, should you repeat stress tests routinely? The first part of that is basically there is a relatively high false positive rate of stress tests, and that's the problem. So much like any intervention depends on the risk in the population, screening tools depend on the risk in the population. And so if you're healthy and asymptomatic and you come in for a stress test, there is a fair chance that a positive result will be a false positive. And what unfortunately happens is that false positive non-invasive test, like a treadmill test, may lead to a invasive test. So like a cardiac catheterization, that is not without its own risks. So the risks of that include stroke, major bleeding, infections, and heart attack. And I'm sorry to say I've practiced long enough now that I've seen low-risk people come in for routine cardiac catheterizations and leave with new heart valves, leave with stroke, or leave with new bypass grafts. So that you raised an excellent question. It's something we struggle with, who to stress, who not to stress. But the main reason is the false positive rate is high. Now, 20 years from now, our scans are better, more accurate. This might change. This might change. The second part of that is, should you do routine follow-up stress tests? The short answer is yes. It's a little more complicated than that. What was happening was that cardiologists had stress cameras in their office, and we like to do stress tests because we get paid to do them. So there was a bit of a backlash from that. But there are recommendations and guidelines. So after about 5 years after bypass grafting, it is reasonable to have someone come back and do another treadmill stress test. Usually that is done with some form of imaging because, again, the probability of having an abnormality is higher.
And that's whether it's CABG, TAVR, or stent.
Yeah. So
PCI.
yeah, the good news is TAVR is if you don't have any coronary disease, you won't need another stress test. Is the good news. But PCI, probably about 3 years. I think it's in the guidelines, but I have to be quite honest with you. If I had someone who had a history of, coronary intervention, and they came back and saw me in the office, and they're doing absolutely fine, and they're exercising, having no symptoms, I wouldn't put them through a stress test. Yes, madam.
With the coronary artery calcium, is there any correlation with osteoporosis?
That is a great question, and I have to be honest. Sorry, just to repeat the question, is there any association between coronary calcium and osteoporosis? I have to be honest with you, I don't know the answer to that question. Yeah, I'll have to look that one up for you. I guess broadly thinking about calcification as it applies to, say, arteries and metabolism of calcium within your body, the calcium we see in the arteries and on the valves of your heart are actually response to inflammation. And so what actually happens over time is the lipid particles get into the lining of your heart and they cause irritation, and it triggers an immune response. So your white blood cells actually go in there to mop it up. Now, some of them change from white blood cells to actually osteoclasts, the cells that produce calcium, and that's why they calcify over time. So it's more of an inflammatory condition rather than, say, a condition with bone metabolism, but I'm not sure if there's a clear correlation.
And what would cause the inflammation?
Yeah, so excellent question. So vascular inflammation, cholesterol, high blood pressure, smoking, autoimmune diseases, so diseases that cause chronic inflammation. If you talk to your dentist, they will tell you that chronic tooth disease causes inflammation, and that will lead to the development of plaque in your arteries. Yeah. I'm sorry, madam, you had a question. I'm taking all the questions. I'm sorry.
You did a great job.
How bad does the cat get with stress in your chest? Because we all have tightness, we all get tired, we all get stress. How bad does that get before you think you're having a heart attack?
So the question was, how bad does the tightness in the chest, stress or exertional fatigue need to be before you need a stress test or worry that you're having a heart attack? So I guess if you're having tightness when you're exercising, that would be an alarming symptom to me, and I would put you through a stress test for something like that. If you were feeling tired, but you've been feeling that way for years, and the more you exercise, the more you felt better, I would be less concerned. A heart attack itself, it would be a prolonged episode of chest pain, or shortness of breath, or really terrible fatigue. And so that can be different for everyone.
Yeah, I think the hard thing and the reality is, and this won't sound reassuring, is it's very hard to know. And that I'm sorry is the truth, I've had we see a lot of patients who have chest discomfort. We run all the screening tests and everything is fine, and it was nothing. And we see patients with very atypical symptoms come in and they've had a major heart attack. So I'd love to tell you I have a clear answer for you, but I think it's difficult to tell. Beyond physical exertion, emotional stress can trigger heart attacks as well. And so certainly if you're in a emotionally very stressful situation, you're feeling chest pain and tightness, or even some of the other symptoms we talked about, it's possible that could be related. And this is not an easy thing to figure out without EKGs and testing and things like that. You know, when I started practicing, I was very sure everything was by the textbook. And, you would have the classic symptoms of chest pain radiating to the neck and the jaw. And then I practiced for a little longer and I thought I knew exactly, nope, that's not it. It's this way. This is how it presents. And now I'm getting gray here and I've been doing this a while, and I know that unfortunately it can present in a lot of different ways, and it's very hard to be sure. So you've got to sort of take the whole picture, listen to your patient, and I know no one wants to go to the emergency room. I know that. We probably get, we got staff here who answer our phones for us, probably get 3 or 4 calls a day with chest pain. I'm at home and I'm having chest pain. And sometimes we just need the emergency room to be able to tell us, is this something dangerous or not? And so I admit that's not a great answer, but it is unfortunately the truth.
I'd like to say something to that. A friend who had somebody
Very close to them recently who started feeling bad sitting at the kitchen table, didn't make a call and died.
Yeah.
Afterward.
Yeah. So this is the
It's a
concern.
great example.
Yeah. Yeah.
Is it fair to say anything that's abnormal for you?
Yeah, unfortunately. I mean, and again, it's
You know when something is wrong.
Yeah.
Yeah.
Like I said, there's no way, even if you saw one of us every 3 months, right, you're gonna know something is wrong before we are.
yeah, man.
Yeah, what could be going on with a woman's heart? A woman who can climb the mountain, walk for 5 miles, exercise, and she's fine, nothing's happening. And yet, same woman who can wake up in the morning and have heart palpitations, some shortness of breath, feeling not so good, crazy, and that lasts for maybe sometimes 10 minutes, sometimes less, sometimes more.
Yeah.
So
Yeah, if I could go back and reference like that slide, that had the all-encompassing cardiovascular disease. I mean, unfortunately there is a large number of things that could be beyond coronary disease. And I would agree, if someone has excellent cardiovascular health and they have no reproducible symptoms with activity, why do they have some of these other symptoms? There can be other arrhythmias, there can be diastolic heart failure, there could be all sorts of things going on there. So just because you're not having chest pain with activity doesn't mean you don't have heart disease. You, sir, young man with the glasses, do you have a question? No, okay. No, that's okay. You, sir, older man with the glasses, yeah. Yeah, no, it's the slightly balder older man behind him. Yeah. Yeah.
I guess I have more just like an insurance question. When it comes to like Medicare, Medicaid, private insurance, whatever it may be, what do you find is typically covered or not covered or things of that sort?
Yeah.
Because I know that prevents a lot of people coming in from the ED as well. It's, sometimes that big bill that you do that, but you don't.
So
They're not really funding it.
I will say most things done in the emergency room for emergent care are covered. Don't turn the camera off. No. But most things that you come into the emergency room will be covered under emergent care. In our office, if we're ordering a test, it usually goes through a prior authorization. So we have to have a clear indication. We run it to your insurance company. Coronary calcium scores are not covered by any insurance provider.
Never.
As it stands now, because the argument is that it does not change outcomes. We'll see if that changes over time. But when you go and you see your provider, they should be documenting things and making sure they're appropriate. And if that happens, then it should all be covered. Yes,
Can you
madam.
explain to the group the different types of cardiology practices? So we often will send people to an electrophysiologist or cardiovascular, and they don't I think there's a lack of understanding as to why we need to go or send people to different specialties. Can you
Yeah.
just explain that a little bit?
Would you like to take that one?
Spencer. So, Dr. Spencer and I here at Monadnock Cardiology do general cardiology. So, we order things like echoes, ultrasounds of the heart, EKGs, stress tests, and blood tests. I sort of discuss the heart sometimes as a house. So when we're looking at the house, you have the electric system, which is like your electric system in the house. People that have abnormalities within that are people that might have AFib or different arrhythmias. And those people go to basically an electrician of the heart called an electrophysiologist. Sometimes the plumbing, like the plumbing in your house, or the coronaries get blocked up, and we send you to what's called an interventionalist. And they're the ones that use a catheter to take a look at the plumbing and the arteries of the heart. And then the heart valves, which are in between the chambers of the heart, I describe as sort of the doors within the house. And if those become stiff or abnormal, and they need to be replaced, we send you to a structural heart specialist. Did I get all of them?
I think that's
Yeah.
great. Yeah.
Or
All right.
Did I answer your question?
Yeah, thank you. No, that, it's
Oh, yeah.
perfect, because we do get
Yeah.
a little bit of confusion and understanding, so thank you.
Well, I think with electrical too, right, there's gonna be more pacemakers, maybe a leadless pacemaker, things like that.
Yeah, so any electric issue, a lot of them from a really basic standpoint, we treat AFib, more when we're discussing interventions. So it's a good point, should have been more specific. So someone that needs a pacemaker, they need a very special drug that we don't give you here in the office. You need something like an ablation or a procedure on your electric system. Those things we would all send to electrophysiology.
So basically, you're the GP of.
That is exactly it.
This is exactly,
That's
yes.
exactly it.
And we've got that.
Perfect.
Well, wonderful. Thank you all for coming in. I know the weather has been a little adverse there, so I appreciate it. And it's been a pleasure to give this talk with you, and thank you for your questions. I think you all have a hand up there, and some of you are familiar faces, and each will just so you go.
And you.
Okay, great.
Thank you.
Thank you.